another Puscast podcast to review the infectious disease literature with commentary for December 1st through 15th, 2006. This will be my last podcast of this year, I think. I won't do the next one until January. For those who are sick of this intro, please skip ahead to the next chapter. This is brought to you by Pusware LLC, publisher of the Puscast Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at Pusware.com. All opinions are those of Mark Crislip, MD, and Pusware LLC, and not those of Legacy Health Systems, its employees, the IDSA, the IDSO, the AMA, or anybody else with a brain in their head. Now CME accredited. Listen, take the online quiz, and get a half an hour of free CME thanks to Legacy Health System. Also, to mention any potential conflicts of interest, I have not talked to a drug rep nor accepted anything from a drug company in almost 20 years, so all the biases here are my own. Go to nofreelunch.org for details. Not that my honor and integrity are not for sale. They are. I just expect lots of zeros after the one. This podcast is to review the infectious disease literature of the last several weeks and, with commentary, declaim and pontificate on those articles that are of interest to me and hopefully to you. Too much literature out there for that. But I want to get to the point, so I favor breadth over depth and cheap shots over seriousness. Keeping up in medicine is like drinking from a fire hydrant, to quote Dr. Richard Bryant. This is my sip and is aimed at the practicing physician and resident. If you are at all interested to know, a practicing infectious disease doc in Portland, Oregon. I do this to help teach the residents in our medicine program. A good one if you're looking to become an internist. Go to legacyhealth.org. Help me learn and, most importantly, advertise the aforementioned guide. But as gag Hellfront said of another, I'm just this guy, you know. As a warning, it is not called Persiflagers for nothing. The podcast will probably contain snide comments, sarcastic asides, and short rants on political and other contemporary issues. Don't complain that I didn't warn you in advance. Also, I've been called an arrogant subspecialist who does not appreciate the limitations of primary care, so you are warned. If you like this sort of thing, I also recommend my other podcast, the Quackcast, available on iTunes, a look at alternative and complementary medicine with what I like to call evidence-based ridicule. So, now, on to the literature. All the references are online, as are some references of which I will not talk about. What's your risk for getting avian flu? Well, so far there isn't much risk. There was a study that was published in Emerging Infectious Diseases this month that looked at the risk factors for the development of human infection with avian influenza, the H5N1 strain. And they found that the real association for developing this disease was either associating with or preparing sick or dead poultry for consumption or having sick or dead poultry in the household. There did not appear to be any association with spread from human to human, and there was not any spread from other animals to humans. Again, this is probably because the receptors for this virus are only found in the deep airway, so you need to have reasonably close contact and to aerosolized dead bird parts to acquire this illness. Again, it is probably just a few mutations away from affecting human beings by being able to bind to upper airway receptors, and then it's estimated that it may kill 68 million people worldwide in another pandemic. That's why I remain very, very nice to the respiratory therapists in my hospital. They know which vent has my name on it. I mentioned in prior podcasts that the current H5N1 strain, like all influenza, is genetically drifting over time, and the strains that are available now are not antigenically the strains that were available at the beginning of the current epidemic in birds. However, they are stockpiling vaccine to older strains, and the question would be, is the vaccine strain going to be protective for whatever strain gets cut loose in the human population? I was pessimistic in prior podcasts that would be the case, but a recent article in the New England Journal of Medicine suggests that my pessimism may be ill-founded. This was a study that looked at how good the vaccine was against antigenically drifted influenza. They looked at the strains in 2004 when the vaccine was not that homologous to the strain in circulation due to antigenic drift, and they found that even though their vaccine was off, it was still about 77% effective in preventing influenza in people who received the vaccine. They found that the live virus was not as good as the old-fashioned killed virus prep, but they still got reasonably good protection against the strain in the community, despite the fact the vaccine was not a good antigenic match. So I think we can maybe have a little bit more optimism that the strains of vaccine that they are stockpiling for influenza may have some efficacy, although that is a leap of faith. As long as we're on the topic of vaccines, how about that hepatitis A vaccine? How good is it? Well, the series should provide, according to models, protective antibodies for at least 25 years. A recent study that was published in the journal Vaccine looked at normal people 10 years out after receiving the primary vaccine series, and they found that 98% of people still had protective antibody level a decade after their prior vaccination. It looks like if you get the Hep A vaccine, you're going to be protected at least 10 years from getting hepatitis A. And I would ask the person listening to this podcast, have you had your hepatitis A vaccine? Because if you haven't, you're a retard. You'll miss a month of work at least, not to mention the rare cases of patients who get fulminant hepatitis A, and the hassle it will provide to your healthcare establishment if you're found to be positive. So please remember, the 3 reasons we get to live into our 80s are good nutrition, flush toilets, and vaccines. Concerned that by altering the cells of the vagina that oral contraceptives may increase risk for HIV disease. This appears not to be the case in an article published in AIDS this month. The study was done in Uganda and in Thailand, and women were given oral contraceptive pills and looked at the rates of HIV acquisition over time and compared them to other forms of contraception. They found no difference in the acquisition of HIV disease depending on whether or not patients used hormonal agents. However, they did find a slight increased risk in acquiring HIV disease if you had HSV2. Not a big surprise, as things that disrupt the integrity of the cell are known to increase the risk for HIV disease. But it would appear that using birth control pills is not an increased risk for acquiring HIV. The only interesting HIV article this month was published in Clinics of Infectious Diseases and looked at the decrease in neonatal mortality in patients who were given antenatal TMP sulfa prophylaxis. This is a study that was done in Africa, and they continued women on their TMP sulfa through their pregnancy when their CD4 counts were under 200. The interesting effects of this was that there was a decrease in preterm births as well as decrease in neonatal mortality and a trend towards increased birth rates. And there was no problem with kernicterus in the patients who received the TMP sulfa. So not only was it effective in preventing premature delivery in women with HIV disease, but the babies did better after birth if their mom was on TMP sulfa while they were pregnant. How applicable this is to a USA population or Western Europe, I do not know. Review of the monkeypox outbreak that occurred in Illinois in 2004 that was associated with prairie dogs that got infected with monkeypox. I bring this up because this is interesting in that the shipment that brought the monkeypox into the United States included, amongst other things, rope squirrels, tree squirrels, Gambian giant rats, brush-tail porcupines, dormice, striped mice, gannets, and palm civets. Now, people like exotic pets, and I have heard that the illegal importation of animals and birds into the United States is bigger than the drug trade in the United States. People want their weird animals. My opinion is always that people who lack personalities make up for it by having a strange pet. Hi, I'm boring, so I have a pot-bellied pig. Hi, I'm personality, so I have a parrot on my shoulder instead. Be that as it may, it's important to remember that exotic infections will be brought into the United States with smuggled animals, and we have to be on the lookout for these. As mentioned in prior podcasts, the civet is the source of the SARS virus, and imported animals are an important source of potential pathogens. It's predicted that perhaps avian influenza will not reach the United States by way of migrating birds, for example, but rather through imported illegal birds and jobs so they can send bird feed back to their parents in the old country. I usually discuss pediatric cases as I'm an adult practitioner, though I don't act like an adult. But there was an article in the Clinics of Infectious Diseases where they used modern techniques to look at the microbiology of acute otitis media. They punctured these poor kids and they sent their ears off for culture and PCR looking for viruses. The interesting things, first, 66% of people had both bacterial and viruses isolated from their ear, and only 27% had viruses alone. The other annoying thing is that patients sometimes had more than one bacterial pathogen, such as strep pneumo plus Haemophilus or strep pneumo plus Moraxella. The top three organisms were still Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis, but the number of viruses in there was quite remarkable, ranging from RSV to metapneumovirus to Bocavirus, enterovirus, influenza A virus. It's really a hodgepodge of potential viral pathogens that could be isolated from the inner ear of children. The good thing is that unusual bacteria were uncommon. There were only a smattering of Staph aureus, or should that be Staph aureus, and one kid who had a Pseudomonas aeruginosa. The vast majority of otitis medias are still strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis, sometimes all the above, and almost always associated with concomitant viral infections. And as long as we're on the topic of kids, briefly mention an article published in Thorax that showed an association primarily in girls between being positive for chlamydia pneumoniae and having asthma. In this study, the higher the IgG levels were against chlamydia pneumoniae, the more likely they were to have wheezing. I don't know if this is going to pan out. It's only significant in young girls makes me think this was a statistical fluke, but we'll see. The treatment of community-acquired pneumonia over the years has always been excessive durations of inadequate amounts of therapy. It often seems that we send patients home on a little bit of long-term antibiotic, when it's probably best always to treat infections with short courses of high dose. There was a recent study in the journal Medicine that compared levofloxacin 750 milligrams 5 days versus 500 milligrams for 10 days and found that patients did as well and by some criteria got better faster on the short course high dose levofloxacin. It seems reasonable to me, and the usual duration of antibiotics has more to do with the number of fingers we have on our hands than it does the duration needed to cure patients. Certainly a 5-day course of therapy for pneumonia would be better than a 10-day in terms of cost as well. There's been studies out now to show that 1, 3, and 5 days can treat most uncomplicated community-acquired pneumonia, so 5 days is not an unreasonable duration. Move up the phylogenetic tree to the meningococcus, but back to the issue of vaccine and how long it lasts. This was a study in CID that looked at how long antibody against the group C meningococcus vaccine stays in kids aged 13 to 15, and they found that you could find bactericidal antibody levels for about 3 years after immunization with the meningococcal C vaccine. Kid gets his shot on his way to college for meningococcus, at least for the C, he's probably protected for the duration of his college career, presumably if he goes to college for only 4 years. And it's all about polymorphisms, and that's true in another study published in CID. Now let's put it in perspective. There are these mannose-binding lectins. These are proteins that are found on your nasal pharynx that are responsible for the initial binding of organisms such as meningococcus. They include some surface proteins known as SPA, SPD, and these are found also in the nasopharynx and respiratory tract. Meningococcus will bind to these proteins and interact with them in various ways. Now, they looked at patients who lived and patients who died of meningococcus, looking for changes in their SPA proteins that line the nasopharynx, and they found that patients who had a specific polymorphism, if you care, it's a substitution of a glutamine with a lysine at residue 223 in the SPA2 carbohydrate recognition domain, ooh boy, that's a mouthful, and I'm obviously reading this right off the screen, they were much more likely to both get disseminated meningococcal disease and die. So basically, there's a predisposition if you get colonized with meningococcus in the ability of your snot to modify the virulence of meningococcus. And so polymorphisms in snot determine whether or not you can live or die if you should be exposed to meningococcal disease. I think that's fascinating. I really do. Will turn out to be due to our genetic predisposition. Kitty, kitty, kitty. Oh, damn cat bit me. So, what's the microbiology of a cat bite? This was looked at in Sweden, where they looked at cat bites in a series of patients who were dumb enough to get bit by a cat, and they found that Pasteurella multicida occurred in 70% of the patients, that anaerobes were found in 16%, but curiously, Staph aureus was a rare cause of infection. The other interesting thing, which has been mentioned in other studies, is how quickly Pasteurella infections will begin, and the pain, erythema, and edema can start as early as 3 hours after a cat bite when it's due to Pasteurella. So again, Pasteurella multicida, which is often found in a cat bite, is still the most common cause of infection due to a cat bite. Antibiotic-associated pseudomembranous colitis, but there's also antibiotic-associated hemorrhagic colitis. These are patients who've been on antibiotics and get a bloody diarrhea. When they're scoped, instead of seeing pseudomembranes, what you see are areas of hemorrhagic colitis. What's the cause? Well, in an elegant article in the New England Journal of Medicine this month, it would appear that Klebsiella oxytoca is the cause. They did an elegant study where they fulfilled all of Koch's postulates by taking the organism and injecting it into mice, etc. And they found that this organism produced a cytotoxin which damaged cells. When you put the cytotoxin into animals, they cause the same findings that you see in humans. And so it would appear that a cause of hemorrhagic colitis is Klebsiella oxytoca, and maybe that should be a soft C, and it's Klebsiella oxytosa. No one's ever told me. But this is a cause now, probably, of antibiotic-associated colitis. And if you have someone with a hemorrhagic diarrhea and they're C. diff negative, you should probably be looking for Klebsiella. This study, the antibiotics that triggered the hemorrhagic colitis were ampicillin and Flagyl, amoxicillin clavulanate, which was present in 4 of the patients, and amoxicillin and clarithromycin, which is being used for the eradication of H. pylori. All patients were on oral antibiotics for relatively trivial infections such as sinusitis, tonsillitis, and eradication of Helicobacter pylori when they developed their disease. So it would appear, obviously, that the organism is resistant to these antibiotics, overgrows, and then causes the disease. Bob Dylan said everybody wants to get stoned, but that's probably not true if it's in reference to your urinary tract, because you get problems from stones. Amongst them is sepsis when you get them exploded, i.e. lithotripsy. Now, who's at risk for getting septic from lithotripsy? Well, it's patients who have stones that are bigger than 20 millimeters, who have dilatation of your collecting system. Those patients are 4 times more likely to go on to develop SIRS or sepsis after their lithotripsy. How can you prevent it? Well, in the British Journal of Urology, they gave patients 250 milligrams BID of oral ciprofloxacin for a week prior to their nephrolithotomy, and they found that they had much less sepsis. So a week of Cipro prior to their procedure decreased the relative risk of sepsis by 2.9. It decreased the incidence of infected pelvic urine by about 3 times and decreased the infected stone rate by about half. Take a dead chicken from a chicken farm, and you put them in a bag, and you add some sterile fluid, and you shake it for a minute, and then you culture that to rinse for salmonella. How often will you find salmonella in what's called the rinse of a chicken? It turns out that it's increasing over time throughout the United States, And the percentage of establishments that have Salmonella enteritidis on their chickens has gone from about 8% in 2001 to 31% in 2005. So Salmonella enteritidis is increasing in the chicken population that we subsequently eat, and explains in part why both salmonella rates are increasing in the United States, and that eating chicken is a risk factor for developing a Salmonella enteritidis infections. So the take-home message is beware the chicken. He is becoming more resistant, and multi-drug tuberculosis is increasing in incidence across the world. Where do you need to worry about high rates of MDR-TB? This study was published in The Lancet and looked at the rates of drug-resistant TB between the year 2000 and 2002. The places that have lots of increased risk for MDR-TB, here defined as greater than 6.5%, were Latvia, Lithuania, China, Israel, Estonia, Uzbekistan, Russia, and Kazakhstan. So when Borat comes to your office coughing, be leery that he has a multi-drug resistant tuberculosis. They found in 2004 424,000 cases of MDR-TB, half of which occurred in China, India, and Russia. So MDR-TB is increasing across the world, and our ability to kill this bug is declining over time. One of the many things to look forward to for our children in the future. Non-tuberculous mycobacterium, i.e. the atypical mycobacterium, are frequently isolated in the sputum, and what to do about them can be problematic. In a study that was published in the journal European Respiratory Journal, to be redundant, looked at non-tuberculous mycobacterium bronchiectasis. They found 98 patients who presented to a clinic with NTM in their sputum. I think the take-home message from this study was that a high proportion subsequently turned out to have cystic fibrosis. So that if you have a patient who is presenting with bronchiectasis and non-tuberculous mycobacterium in their sputum, think about cystic fibrosis. Antibiotics associated with the development of breast cancer, that's been an issue that has been raised before. In this study that was published in the journal Cancer Epidemiology, Biomarkers and Prevention, they looked at antibiotic use and the risk of breast cancer in over 2 million patients in a healthcare plan. Of these patients, 18,000 went on to develop breast cancer over about a 9-year follow-up period. And they conclude from this study that there were no real association between the use of outpatient antibiotics and the development of breast cancer. They found very slight increase association with tetracyclines and macrolides, but they suggest that this data could be explained by uncontrolled co-founding by the diseases being treated or by other factors. So that the data from this epidemiologic study at least suggests there is no relationship between the use of antibiotics in the outpatient setting and breast cancer. I, for one, cannot think of biologic plausibility for why this would be the case. Do have effect on humans over and above their ability to kill bacteria. There are things published in the last 2 months, but I will not discuss these articles in particular. There's a nice review of the antibiotic rifapentine in the Clinics of Infectious Diseases. There's also a review of the organism Clostridium sordelii in Clinics of Infectious Diseases this month. And then the CDC has published in the MMWR vaccine and pertussis summary information for those of you who deal with that issue. But that's the end. This brings us to the end of the Persiflagers podcast for December 1st through the 15th, 2006. Review of the ID literature with commentary. References, including some not mentioned in the podcast, are available on the website. Remember, this is CME accredited, so listen, take the online quiz, and get a half an hour of free CME thanks to Legacy Health Systems. Brought to you by Pusware LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. If you like this, listen to the Quackcast, where I use evidence-based ridicule to evaluate alternative and complementary medicine. This is available on iTunes and at quackcast.com. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. Again, a special shout out to the people of Ireland who have accounted for 20% of my income from this, a whole $20. Copyright under the Creative Commons license at creativecommons.org. The music is by my 12-year-old son improvising on his guitar. For comments, feel free to email me at mcrislip@pusware.com. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.